alaikum warahmatullahi wabarakatuh. This case report from the Graduate Endodontic Clinic, University of Minnesota, was published this month, January of 2026. Describes a comprehensive non-surgical and surgical endodontic management of a 32-year-old woman with vitamin D resistant rickets who presented with a chronic extraoral sinus tract on the chin and extensive periapical pathology in the mandibular anterior region. Vitamin D resistant rickets cause a hypophosphatemia and defective mineralization of the bone and dentin, producing enlarged pulp chamber and pulp horns reaching to the dentino-enamel junction, which predispose teeth to spontaneous pulp necrosis and large periapical lesions, even without a caries or trauma, and also lead to hypermineralized bone, thinned cortex, and absent lamina dura that compromise healing. Clinically, the patient had an extraoral cutaneous sinus tract, histologically confirmed as a dental in origin, intraoral swelling with buccal and lingual plate loss around teeth 24, 25, and 26, intermittent dull pain, and questionable vitality in several mandibular anterior teeth. CBCT showed a large through and through a periapical radiolucency involving 24, 25, and 26, a separate lesion at 22 with a radiographic evidence of enlarged pulp horns at the dentino-enamel junction. The diagnoses were pulp necrosis with symptomatic apical periodontitis in 22 and pulp necrosis with chronic apical abscess in 25 and 26. With 23 and 24, initially was testing inconsistently. The plan was staged to be non-surgical root canal treatment with calcium hydroxide in 22 and 25 and 26, and also close monitoring of the sinus tract behavior, possible aspiration, irrigation of the lesion, and delayed a surgical intervention if needed. Non-surgical treatment was done rotor instrumentation, 5.25% sodium hypochlorite with passive ultrasonic irrigation and repeated calcium hydroxide dressing led to partially symptom and range reduction, but not complete healing. A root canal treatment on 25 and 26 was eventually completed with modified continuous wave technique and bioceramic sealer, and aspiration yielded 4.5 ml of exudate that was evacuated and the cavity lavaged, yet a persistent extraoral tract and a new intraoral sinus tract at 25 remained. At 4 month follow-up with CBCT showing real reduction and possible expansion of the lesion, by that time 22 showed radiographic improvement and was asymptomatic, but 24 had lost a cold response, remained EPT positive, and tender and on axis was found necrotic. And on axis was found necrotic, so it was diagnosed with pulp necrosis and treated non-surgically, while 23 was left untreated because its apex was not involved radiographically. Given persistent sinus tract lesion enlargement, and patient's compromised healing potential, surgical endodontic treatment of 24, 25, and 26 was performed using microsurgical approaches, full thickness flap with vertical releases, complete curettage of a cyst-like lesion, root end resection, and retrofilling with BC fast set root repair material, management of the lingual cortical perforation with a resorbable membrane, and filling the defect with a 70 to 30 mix of freeze dried bone allograft and demineralized freeze dried bone graft allograft as well, covered by an additional membrane to achieve guided tissue regeneration, followed by primary closure. Histopathology confirmed a radicular cyst with a chronic and acute inflammation, abscess formation, fibrosis, and reactive bone, and remnant of epithelial lining, supporting the diagnosis of inflammatory periapical cyst. At 3.5 months post-surgical review, the extraoral and intraoral sinus tract had fully resolved clinically, and radiographs showed ongoing osseous healing. And at 12-month follow-up, the patient remained asymptomatic with physiological mobility, minimal chin scarring, and radiographic evidence of re-establishing periodontal ligament and lamina dura and near complete osseous regeneration around 25, 24, and 26. And they concluded that despite of the traditional guarded prognosis due to the defective mineralization and impaired healing in vitamin D resistant rickets, a combined non-surgical and surgical endodontic strategy incorporating a guided tissue regeneration can produce a favorable outcomes. And thank you.